Ladies and gentlemen, today we are here to discuss how to code for patients who are being treated for a pulmonary embolism. Prior to 2009, your coder could simply pop in one code and then pop off for a tea break. But now, not so fast.
Huh?
Now, there are not one, not two, but three codes you must know to accurately describe a pulmonary embolism diagnosis. That wasn't mine. Where was I? Oh, yes. Oh! Effective October 1st, 2009, a new code, ICD-9-416.2, or now I-27.82 in ICD-10, was created to describe patients with chronic pulmonary embolism who are being maintained on anticoagulant therapy for an extended period of time, to distinguish these patients from those being treated for an acute pulmonary embolism. To code for chronic pulmonary embolism, you must now include two codes, I-27.82, ICD-10 for chronic pulmonary embolism, and Z79.01, ICD-10 for long-term current use of anticoagulant if there is a continuous anticoagulant therapy. To code for acute pulmonary embolism, NOS, or not otherwise specified, you would use I-26.99, ICD-10. Yes, we have a question. Speak up, sir.
Professor, how do we know whether the diagnosis is acute or chronic? Is there a specific time frame that distinguishes acute from chronic pulmonary embolism?
Delightful question, sir. These codes should be assigned on the basis of the provider's documentation. Coders should query the provider for clarification if the documentation is unclear. Is it acute or chronic? Pulmonary embolic disease may be acute or chronic or long-standing, having occurred over many weeks, months, or years. In the majority of cases, acute pulmonary emboli do not cause chronic disease because the body's mechanisms will usually break down the blood clot. An acute embolus is usually treated with anticoagulants, such as intravenous heparin and warfarin, or oral Coumadin, to dissolve the clot and prevent new ones. For acute pulmonary embolism, anticoagulant therapy may be carried out for 3 to 6 months. This then continues to be the acute event. Therapy is discontinued when the embolus dissolves, and we would then use Z86.711 for a personal history of pulmonary embolism.
But Professor, what happens if the embolism comes back or leads to pulmonary hypertension?
In patients with recurrent pulmonary embolic disease while on blood thinners, or patients who cannot tolerate blood thinners, a filter can be placed to interrupt the vena cava, the function of which you should all be familiar with. This then is the chronic disease state for which the proper choice of code is I-27.82 and Z79.01. For the anticoagulant therapy, if the patient is tolerating it, and Z95.828 for the personal history of a vascular implant.
Does DVT have a similar explanation?
Yes. The documentation of an acute versus chronic deep vein thrombosis and coding thereof is very similar. Typically, an acute DVT is considered a new thrombosis that requires the initiation of anticoagulant therapy. A chronic DVT is an old or previously diagnosed thrombus that requires continuation of anticoagulation therapy. However, specific code assignment is based on the physician documentation. The coder cannot assume whether the DVT is acute or chronic unless the physician documents the acuity. A patient with a history of DVT receiving Coumadin or requiring a greenfield filter will require additional clarification before the final code assignment can be determined. The Coumadin may be prescribed for prophylactic purposes to prevent recurrence or as a treatment for chronic DVT. The greenfield filter may be inserted for acute chronic recurrent DVT or the susceptibility for recurrence. The physician is responsible for providing the acuity of the condition. There are no specific guidelines for when DVT is considered chronic. The code assignment for chronic DVT is based solely on the physician documentation. These links will take you to the ICD-10 CM guidelines, the 2017 crosswalk of codes to HCC and RxHCC categories, and to the most current listing of ICD-10 CM codes on the CMS site. Please feel free to muck about in them for clarification and further edification.